Hi, Dr. Bernard here. This is my in-depth channel, Heme Review. NE is a 30-year-old man presenting to primary care for a regular checkup. He tells the doctor that starting around 7 months ago, he started feeling like there was a pit in his stomach. This wouldn't last for very long, but sometimes he'd feel an overwhelming sense of doom all throughout the day, like something in his life was ending. This wasn't permanent, it didn't happen all the time, and this was only something that was brought up when he was asked. He didn't actively think about this. Physical exam revealed that NE had hypertension. His blood pressure was 190 over 110. You want to be around 120 over 80, especially if you aren't known to have other health problems. And aside from that, he was mostly an otherwise healthy man emerging into his 30s. But hypertension of this severity needs to be treated. And why? This isn't something that always gets explained, but we can cover it in just a few points. The heart is a muscle. When pressure is high, we can guess that the heart is working harder than normal. What happens when muscles work more than normal? They get bigger. They hypertrophy. If you're talking about biceps, triceps, quads, glutes, lats, maybe you want hypertrophy. But when we're talking about the heart, we don't want that. Thicker walls of the heart means that it's harder to eject blood to the rest of the body. And cardiac hypertrophy is permanent. You can't just let the heart rest like you can skeletal muscle, because if you do, you die. So if the heart is working harder all the time, it will need more oxygen than normal to function. And over time, you might be eating foods that are slowly narrowing the vessels that supply blood and oxygen to the heart. So in the setting of hypertension, you could more easily get the heart into the realm of not getting enough oxygen to function normally, and that is called a heart attack. The blood vessels and the heart are a closed system, so increased pressure means increased chance of popping a blood vessel in the brain. Now you have a hemorrhage. Over time, the increased pressure also gets to the kidneys, damaging them. So with high blood pressure at a young age, you're setting up the patient to undergo permanent changes in their body over time if you don't treat them. And because NE's blood pressure was so high, so much more than 140 over 90, he was given a combination blood pressure pill, 2 medicines in one. But what exactly were these medicines? The guidelines tend to change a bit when it comes to treating hypertension over the span of years to decades. There's a lot of different medicines to treat this because there's a lot of different ways that blood pressure can be modified because it's that central of a vital sign. One of these is through a modification of a kidney hormone pathway called the renin-angiotensin-aldosterone system. This is something that's been present in many complex living beings over hundreds of millions of years. In humans, how does this work? Well, it's easier to understand it in terms of need. When humans are dehydrated, the kidneys need a way to communicate with the rest of the body that it needs to hold on to water. The body's 50 to 60% water, so you want to not lose too much. There's mechanoreceptors in the arteriolar walls of the afferent arterioles in the kidneys. When there isn't as much stretch, it means that renal perfusion has decreased. It senses volume loss, and this prompts the granules of the juxtaglomerular cells to release renin into the circulation. This isn't the only known mechanism. When sodium and chloride go to the distal convoluted tubule, it gets sensed by the macula densa. That triggers renin release. Increased adrenaline release also prompts renin release, and negative feedback from the renin-angiotensin-aldosterone system itself also influences renin release. But what is renin? Its other name is angiotensinogenase. The ase suffix means that it's an enzyme that breaks something down, like how lactase breaks down the sugar lactose. So renin breaks down angiotensinogen, and the ogen suffix also has meaning. In this case, it's the precursor or generator of angiotensin, which is the second name in the renin-angiotensin-aldosterone system. Angiotensinogen is made in the liver. It circulates around in the blood. Renin cleaves it into angiotensin 1, which has no function by itself in the body, but angiotensin 1 reacts with another enzyme that's made in the lungs called angiotensin-converting enzyme, ACE, and it gets converted to angiotensin 2, which is active in the body. It constricts the blood vessels because remember, the kidneys have signaled to the body that it needs to hold on to water. So now we're supposed to be in a state of volume depletion or not enough water. This raises blood pressure, and it also goes to the adrenal glands at the top of the kidneys to stimulate the release of aldosterone, which is the final step of this pathway. But just from here, we've already come across 2 different ways that the blood pressure can be managed with medicines. The first is ACE. We can block that. How did we find that out? Well, since at least the 1950s, Brazilian banana plantation workers were known to collapse after they'd get bitten by pit vipers. They quickly identified that the reason for this was because it was lowering their blood pressure. Brazilian scientist Dr. Sergio Henrique Ferreira had isolated something from the pit viper venom that appeared to interact with ACE. And as it was studied more over the next decade, derivatives were developed, which led to the creation of the first ACE inhibitor, captopril. We don't use that anymore so much because its sulfur group causes multiple reactions, but it was the first of its kind. And this is one of the medicines that Eni was given to control his blood pressure. Medicines that end in pril are ACE inhibitors like enalapril, lisinopril, ramipril. But from the pathway, we also described a second way that we can control blood pressure. Angiotensin II vasoconstricts. This means that there exists receptors that receive angiotensin II to interpret its signal to vasoconstrict. If there's a receptor, then it means that possibly we can act on that and we can block it. And it turns out, yes, we can. And that medicine is an angiotensin receptor blocker, ARB. Both ACE inhibitors and ARBs cover a range of ways that we can control blood pressure, manipulating an enzymatic hormonal pathway to disrupt signaling, or blocking the signal of one of the hormones in that pathway that constricts the blood vessels. In reality, Eni could take either one of these as one of the medicines for his hypertension, but he may not want to take both of them together because they act on the same pathway, one being downstream from the other. But this segues nicely into the second medicine in that combination that he can take. If blood vessels can contribute to blood pressure control by how dilated or constricted they are, how could we use that mechanism to our advantage in the setting of hypertension? Well, blood vessels are a smooth muscle. This would mean that their cellular signaling for contraction would hinge around calcium. So, can we block calcium with a medicine? Yes, we can. These medicines block the inward movement of calcium into vascular smooth muscle so that vasoconstriction is limited. But remember, the heart is a muscle too. So there's another type of calcium channel blocker medicine that works primarily in the heart, not really centered on the blood vessels. And limiting how hard the heart beats is another way to control blood pressure. But for Eni, we probably don't want to do that just yet. Inhibiting ACE and relaxing his blood vessel smooth muscle should be good enough to reduce his blood pressure. Because remember, he's young. We want to lower it, but we don't want to start him on too high of a dose because we want to have room to modify that dose without adding him onto new medicines. And everything was going well. His blood pressure was under control. Something that the primary care doctor told Eni was that he might need to be on this medicine for the rest of his life, done that way to set expectations for exactly what was happening. Over the next 12 years, Eni's doctor would notice that Eni would have difficulty in controlling his hypertension. First, his combination medicine dose was maxed out. When that didn't work anymore, they added him on an additional diuretic, a thiazide that pushes sodium ion into what becomes urine to draw more water out of the blood. But one day, 10 years later, something serious happened. Eni had developed a kidney stone, nephrolithiasis. This had been going on for a while. He had more than one. He felt when these would come out, and he told the doctor about this. When Eni was examined further, his primary care doctor referred him to a urologist. Eni had stones in his bladder too, and it was time to physically remove them. Before the operation, the medical team found that Eni had hypokalemia, low potassium presence in blood. They replenished his potassium, and then they did the surgery, and everything was fine. But at follow-up, they found out that Eni's potassium was low again. They kept needing to increase the dosing frequency of the potassium chloride after they replenished him, and then they sent him home. And as the years kept passing, they kept needing to increase the dose and the frequency of potassium chloride tablets because his hypokalemia kept worsening. He didn't experience many symptoms, likely because this was chronic, happening over time. So his body was still adapting to it, but still dangerous nonetheless. Potassium is important for signaling for muscle contraction. The ratio of intra and extracellular potassium is the most important factor of determining resting membrane potential. When the ratio is disturbed, you're going to have issues in creating and propagating action potentials to signal for contract or relax. So when serum potassium is either too high or too low, you'll have issues with muscle contraction, the most deadly one being the heart no longer beating. But hypokalemia wasn't his only problem at this point. Even on 3 medicines, Eni's hypertension persisted to the point of being 190/100 still. Typically when you get older, you can expect some health changes, but hypertension that's difficult to control on 3 different medicines means something. He's not on suboptimal therapy. Maybe he's not taking his medicines. That's a problem of medication adherence, but he's been consistently picking up refills for the last 22 years, and he's never been late to a single routine primary care visit. So this probably isn't the case. His lifestyle and his diet could be a factor too, but visually, he's not overweight. He does some moderate exercise as he was instructed to, and he's not taking other medicines other than the 3 blood pressure medicines and potassium chloride. Clearly, something is still happening inside of his body causing this, but what is it? This brings us back to all the different ways that blood pressure can be controlled. Take the inverse of drug mechanism of action in this case. One of the body's control mechanisms has something wrong, causing blood pressure to be uncontrolled. Kidneys and fluid balance. That impacts blood pressure. Is it the problem? Probably not, because a blood test can quickly find if he has kidney failure, and he doesn't. He's not overweight or obese, so it's not diabetes or metabolic syndrome. He didn't have that when he was first found to have the hypertension anyways, and he still doesn't have it years later. Maybe he has sleep apnea, but he'd have a headache, daytime somnolence, fatigue, morning confusion with difficulty concentrating, personality changes, depression. He doesn't have any of that. He could also just be taking a ton of stimulants and not telling anybody, but to put it colloquially, he'd be tweaking. You'd be able to see it, and the severity of this hypertension would make it extremely obvious, especially if he had been doing it for this long. So that's probably not it either. And this leaves us with just a couple of options now. If this were to be toxic from ingestion of something, well, there's 2 things that could cause hypertension with hypokalemia. One is licorice, and not licorice flavored candy like you find here in the United States under the brand name of Twizzlers. I mean the actual herbal medicine licorice. I made a video on Chubby Emu about a man who ate actual licorice candy that was bought from an ethnic supermarket in Boston that imported them from Asia. The other one is chewing tobacco. Cortisol is a stress response steroid hormone that's made in the adrenal glands on top of the kidneys. It's known as a glucocorticoid. The stress described here is physiologic stress. So in this case, we're talking about inflammation, infection, and other obvious factors causing impact to normal homeostasis. So in this context, we're thinking of cortisol as a signal for the body to increase blood glucose levels, to stimulate lipolysis as a means to increase the availability of fat as energy, and to break down protein so that it can be converted to sugar in the process of gluconeogenesis. It holds onto water and sodium, increasing blood pressure. The body doesn't really want cortisol hanging around for so long, so it has a feedback function to break it down to cortisone via 11-beta-hydroxysteroid dehydrogenase. Licorice also contains glycyrrhizic acid, which gets metabolized into glycyrrhitinic acid, which looks like cortisol. It competitively inhibits 11-beta-hydroxysteroid dehydrogenase. This means that someone eating too much herbal licorice can accumulate too much cortisol. And why is this important? Well, it brings us back to aldosterone. It's made in the adrenal glands alongside cortisol. Aldosterone is a mineralocorticoid. Cortisol is a glucocorticoid. The mineralocorticoid receptor cannot distinguish the difference between aldosterone and cortisol. And actually, cortisol has 100 times more affinity for the mineralocorticoid receptor in the kidney. So this means that in the setting of high cortisol, like when herbal licorice is consumed, the kidneys behave as if huge amounts of aldosterone are in the blood. And because aldosterone is the hormone that tells the body to hold on to water at the expense of potassium, it causes hypertension and hypokalemia together, which is what NE had. But he didn't eat any herbal licorice. Chewing tobacco can also do this too because it blocks 11-beta-hydroxysteroid dehydrogenase. But NE didn't use that either. So this narrows down his problems to 2 potential things now. One is that he has an incessant glucocorticoid excess. This could be Cushing's, specifically the one where the body makes too much cortisol nonstop. Or he has constant incessant aldosterone excess. This primary aldosteronism could be caused by a tumor, likely in his adrenal gland, that just releases aldosterone nonstop. So, how would we be able to tell the difference between the 2? A CT scan with contrast of his abdomen revealed a 1.5 centimeter left adrenal nodule. At 8 a.m. in the morning, a blood sample was collected from him. This was blood as it exited the left adrenal gland. In the sample, they measure both the aldosterone and the renin levels. This difference between the beginning of the pathway and the end of the pathway is used to determine if there is primary aldosteronism. But let's think about this. Which medicines would interfere with these measurements? We know that NE was on an ACE inhibitor. This would mean that near the beginning of this pathway, there is some interference inhibiting ACE. That would mean renin levels would increase because the body would think that the mechanism isn't functioning as it should. This would mean that if the measured renin level was a little higher than what the test should return, that wouldn't rule out the fact that he has primary aldosteronism. But for NE, he did have all three of these problems at the same time in extreme forms: spontaneous hypokalemia, suppressed plasma renin, and high plasma aldosterone, all well beyond the normal limits. And with CT imaging, there was no other diagnosis that can explain all of these findings together. NE had an aldosteronoma. The excessive aldosterone secretion told his kidney to hold on to water while excreting potassium, causing hypertension and hypokalemia. ACE inhibitor wouldn't work because the entire renin-angiotensin-aldosterone axis was disrupted by aberrant direct aldosterone release. The action of the thiazide diuretic may have worked at first, but could not outpace the action of the tumor. And dihydropyridine calcium channel blocker would still not be able to help control the hypertension. But what significance does knowing this have? Well, on the Chubby Emu channel, I recently described two patients who used diuretics for their bodybuilding preparation. One used a thiazide and ended up with hypokalemia, among other issues from more than just thiazide use, and another used spironolactone, an aldosterone antagonist, and had hyperkalemia. Both are relevant to NE's case, but the Spiro is the one to pay particular attention to. Spiro is commonly called a potassium-sparing diuretic. Almost 15 years ago, I remember people I was training with at my hospital would always bring up, call it an aldosterone antagonist. Potassium sparing helps recognize the hyperkalemia that can come from problems involving it. But it's better to understand the mechanism by which it functions, because it isn't a diuretic on the account that it spares potassium, but rather it's a diuretic by blocking aldosterone with a potassium retention as a consequence of diuresis. Funny thing is, on Google search at the time of me recording this, it still does appear as potassium-sparing diuretic. Another medicine that does the same thing as Spiro is eplerenone. Sometimes you're going to be dealing with somebody who doesn't know very well, and they might encourage one to be on both Spiro and eplerenone. Don't do that, that's horrible. Going back to the bodybuilding point, renin-angiotensin-aldosterone manipulation has been performed for a very long time. I never did bodybuilding. There was no way that I would ever be able to get that lean, but I was around it during my time at the powerlifting gyms when I lived in Illinois. I remember talking with a coach about drawing out. That's the process of getting that skin-tight appearance when your body fat percentage has dropped down to maybe like 3% or less. I was told that I was never lean enough to do it. Anyone who's ever experienced this, my heart goes out to you, because it definitely doesn't sound like a good time. But the method to do this without taking any exogenous substances went something along the lines of drinking 3 or more gallons of water in a day and holding all salt intake. So people would eat boiled chicken breast, no seasoning. They would basically get their bodies in a total diuretic state where they'd urinate every few minutes. We learned earlier from this video that this would stretch the renal arterioles in a way that would signal to the body that it doesn't need to hold on to water, and therefore there would be no renin release and therefore no aldosterone. There's a period in time where you suddenly cut all the fluid and food intake. I don't remember if this was in the evening or in the morning, but the rationale was that you get the body in such a diuretic state that it drains out even more water from your body than when you had started this method. And by leading the RAS system to suppress aldosterone levels for a time before the body can catch up, you effectively dry out and get that skin-tight appearance, provided that your natural bodybuilding show lean, which is an incredibly low body fat percentage. This probably isn't reliable by itself. It also sounds pretty brutal, so diuretics end up getting introduced. Do you remember NE's case where at first it's go low and go slow? That's actually a central concept in life. You start out things slowly and then ramp it up so that you can give yourself room to do more later. Well, sometimes that doesn't always happen. And some of the doses that I've heard of competitors taking is really high. And combining too many diuretics suddenly is not ideal. I don't have an opinion either way on bodybuilding. I have pretty good memories of working with a bodybuilding coach to lose weight multiple times in my life, and I was able to learn solid natural principles working with him. But on the flip side, you can learn a lot about medicine and toxicology specifically from those who use this gear. I don't judge, but I'm not going to recommend it. It's something that we can learn from, but the mantra remains: if you don't need to put it in your body, don't put it in your body. Now for NE's case, 25 years, like the title says, is pretty excessive, but hormone-secreting tumors are difficult and they take a very long time to diagnose. It's really unfortunate that he had to take those blood pressure medicines for so long, and that he was getting worse all throughout this time with no good explanation until he was up for an operation due to very painful kidney and bladder stones, and they were able to look into why his hypokalemia was so severe. NE received a left adrenalectomy. In the center of the gland, they found a group of abnormal cells about the size of a small marble that was responsible for all the aldosterone release. After an uncomplicated recovery, NE's blood pressure was 110/70 without medicines. He returned to just a bit lower than baseline after all these years not knowing that something was growing in his body that wasn't supposed to be there. He was able to make a full recovery. This case is based on one that was shared with me years ago. I came across a news article in early 2025 about a young female bodybuilder who passed away from what appears to be a diuretic accident. I know this world a little bit better than some of my colleagues based on some proximity I had with it during a prior lifetime of mine when I did powerlifting, although it all seems a little bit different now than when I was closer to that world. The hormone pathway regulating fluid balance and medicines used in the system are staples in medicine. And you don't want to deliberately mess with hormones if you don't have to, because the body will fight you, and you don't really want to deliberately mess with hormones if you don't have to, because the body will fight you, and the end result can be permanent changes that will be difficult to reverse. But luckily for NE, his hypertension was treated early. His aldosteronoma was eventually found and removed, and he was able to minimize any detrimental changes to his body over multiple decades. Thanks so much for watching. Take care of yourself and be well.